We've got an interesting evening tonight. I'd like to begin by welcoming everybody to the Coles Colloquium for 2021. As is traditional, I'd like to start with an acknowledgement of country and, in the spirit of reconciliation, acknowledge the traditional custodians and the law of country throughout New South Wales and their connections to land, sea and community. We pay our respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. I just want to give a very brief background to the Coles Colloquium, which we established in 2013 to recognise the multi-generational contributions of the Coles family to Sydney Hospital, to the Saveside Institute, to Sydney Eye Hospital and to the University of Sydney. Sir Kenneth Coles was a member of the board of Sydney Hospital for 22 years and was the chairman of the board for 8 years. This image is from the history of Sydney Hospital, and it comments a great deal about the wisdom and the extraordinary contribution that Sir Kenneth made to the hospital through the very difficult post-World War II years in the 50s and through his leadership in the 1960s for Sydney Hospital. Sir Ken's son, Ken Coles, was really a terrific mentor to me when I started my position as director of the Saveside Institute. At that time, Ken was the chairman of the advisory board for Sydney Eye Hospital, and he contributed a great deal over the 10 years that he was on the board and chairman of the board. And Ken's really played an important part in helping to make SSI what it is today, the 6th ranked eye discipline in the world. Ken also has a long history of service to the university. He was an alumnus from the Faculty of Engineering. He served in a number of committees in the Faculty of Engineering, was on the board of International House and was a member of the University Senate. And this was a photo that his wife, Rowena Danziger, sent to us earlier this year, celebrating Ken's 95th birthday. So with that background, I'd like to warmly welcome Robyn Ward as our 9th Coles lecturer. Robyn is currently the Executive Dean of the Faculty of Medicine and Health here at the University of Sydney. She has a well-deserved international reputation as an oncologist and as a scientist. I've been lucky to work with Robyn since she was a consultant at St Vincent's Hospital, where I also spent a lot of time working. Robyn then went on to become Professor of Medicine at the University of New South Wales, and then the DVC Research at the University of Queensland, and the Executive Dean of the Faculty of Medicine at the University of Queensland, before becoming our current Executive Dean in the Faculty of Medicine and Health at Sydney University in 2018. Robyn's also the chair of the Medical Services Advisory Committee and on the Council of the Australian Academy of Health and Medical Sciences. In 2013, she was awarded an AM for her distinguished service to oncology and to science. And Robyn, it's an absolute pleasure to welcome you to give your keynote address for us tonight on valuing genomics in Australian healthcare. Over to you. Thanks very much, Robyn. I'll stop sharing.
Thanks, Peter. And I'll just share my screen now. And I hope you're seeing my screen okay. So
yes, we can.
Yeah, thanks, Peter, and thanks so much for that introduction. It's lovely to be here with you, and I hope everyone's holding up okay in the never-ending world of COVID lockdowns. I just wanted to start by saying a few words first about the new Faculty of Medicine and Health at the University of Sydney. It was formed on paper in 2018, July 2018, but really only finally came into existence in February 2020, just a month or so before the pandemic hit. So it's had a really interesting start to its life. But having formed the Faculty of Medicine and Health at the University of Sydney, it is literally a very strong multidisciplinary faculty At the present moment, it's training about 10,500 health students, which makes it the largest trainer of health students in the country. And combined, it's attracting about 65% now of the university's research.
Right.
So
really
I think
cool. So you can just put it here. I'll try and fit it in.
I'm here to listen to a lecture and stuff, so I've got a key to lock out though.
No worries. I'll just let you know when I'm about to leave.
Okay.
Whoever that is, please mute their phone.
Great. So, so the Faculty of Medicine and Health is clearly a very strong research and combined multidisciplinary faculty. And one of the key components of that faculty is our major research initiatives, as I've said. And one of those, which we're calling flagships, is Safe Site Institute. So the Safe Site Institute has a very prominent place in the Faculty of Medicine and Health, and very prominent indeed in the university itself. So with that, with that little introduction on the faculty, I wanted to move to the substantive part of the talk. And the first thing I wanted to mention was just to remind people that the cost of healthcare is actually rising at quite a considerable rate. And those costs are largely rising in areas that are around the volume of services being provided and also the unit costs of those services. And that's primarily in this issue, in the bucket of Medicare, medical services and benefits, where you can see the progressive rise in healthcare costs. Surprising to a lot of people, that pharmaceutical benefit scheme, which was the real topic of a lot of conversations about escalating drug costs, have actually progressively fallen over the last few years and have continued really a fairly flat trajectory. And that's largely because a lot of the new technologies are actually not so much in the traditional drugs, but in other areas. And those sorts of areas are things that fit roughly into this sort of mud map of the areas that we spend money on, which is outside drugs. And that's things like professional attendances, rising pathology costs, and also new types of therapeutic procedures, of which I think everyone listening to today will be very well aware of, given the leading role that Safe Site has had in a number of these new therapeutic areas. And I speak here of gene therapy, gene replacement therapy, and advanced cellular therapies. So these types of therapies, as I've said, gene therapy, somatic cell therapy, tissue engineering, all of these things are rising costs and also have a high impact on a small number of patients, but come with high unit costs. And these disruptive technologies, whether you call them omics, drug therapies, digital therapies, all these new technologies are in fact a big transformative influence over healthcare as we proceed through this next decade of healthcare in Australia and internationally. So one of these driving forces is, of course, genomic medicine. And from genomic medicine is everything from the diagnosis of genetic and genomic disorders right through to how those errors are corrected in therapeutic approaches, and how family members and the population at large is managed. The big change in...
Oh, all right. So Sophie just told me to mute.
Sorry,
my microphone for the Coles Colloquium lecture.
Yeah, thank you for muting. Could you mute yourself, please?
See, like I'm going to Zoom.
Thanks for muting, whoever's on an iPhone. Thank you. So the big change here that brought about the transformation and the era of genomics medicine was this big technological change that drove the costs of sequencing down. You know, and everyone's seen this Moore's law diagram that showed that the costs of actually doing a whole human genome was falling at such a rapid rate to less than $1,000 to under $1,000, and this was made genomics a commodity, not something that required massive buildings and billions of dollars of investment just to sequence one genome. So genomic technology sort of landed on the doorstep of healthcare, and at the same time, healthcare wasn't all that well prepared for this onslaught of opportunities that arose as a consequence of being able to access this new understanding of genomes, understanding of where disease came from, how to interpret disease in an entirely different way. And so we were left with this idea of genetic services trying to deal with the impact of genomics on their healthcare. And that led to this idea that there was a very high demand for genetic services. No one really knew how to understand all this genomics. There's this rapid changing, evolving of practice, and guidelines were sort of out of date right at the date that they were launched. And then the diffusion of genomics into specialty areas beyond the hardcore genomics and genetics professional groups into mainstream practice, where the health practitioners had not ever really been trained in genomics, and suddenly it was something that was mentioned in oncology, in cardiology, in eye disease. All of these areas suddenly had to deal with this new onslaught of information. And then from the pathology world, this need to actually get NADA accreditation for pathology tests, the idea of whether people would set up their own tests, or which had been very common practice and was very manageable when you were only managing a couple of tests, but when you're trying to do this en masse became an impossibility. And so the many groups started, and research groups started to say, well, we'll set up our own specialist genomic services. And that one happened in the state of New South Wales with the Garvan as a research institute buying a lot of 10x HiSeq machines in about 2014-15, and saying, well, they would sequence the genomes of the population through that new investment. So what we've realised over the last couple of years is there's been about a 50% increase in demand for clinical services. The workforce demands are really looking like more than 1 FTE per 100,000 population. Our current workforce is about 0.6 FTE clinical geneticists per 100,000 population. We don't have a strong pipeline of career professionals who understand and work in this area. That's been weak for many years, and not many interventions have failed to correct that. And then we know that the current genomics workforce or genetics workforce retires, about a quarter of them retire in less than 15 years. So this idea of how do we rethink our approach to the workforce, should we have genomics or genetic services as standalone services, or does every ophthalmologist and every cardiologist and oncologist and respiratory physician need to actually have a good understanding of genomics and genetics in order to be able to deliver healthcare? And that would not only include specialists, but also our primary healthcare professionals and others, should they all actually understand genomics as a matter of course. So what I'd like to do now is just to tell you a little bit about how at the same time these changes were being sort of landed on the health system, what was happening in a research setting. And this really is a story around the Australian Genomics Health Alliance, an alliance that began in 2016 when the NHMRC called for a targeted call for research applications in genomics. And I was one of the principal investigators on this grant. Kathy North from the Murdoch led the grant. And this is the story of what happened over those 5 years and what has happened subsequently to really try and create a new model of undertaking research that has immediate relevance to healthcare. So the aims of the Genomic Medicine Initiative, which was called for, as I said, by NH and MRC, was to demonstrate how patient benefit could be maximised through the application of genomics, to look at how it could be made cost effective, to implement practical strategies that planners, health system reimbursement agencies and others could use, and then to build this rapid translation capacity. So if you like, it was sort of a health services research project on speed. And the way the project was initially designed was around 4 programs of work, which is shown in the vertical blue colours there across the screen, which, as you see, are really all around large scale issues that impact on genomics. And then essentially a set of demonstration projects were cross-run across all of these 4 programs of work, one around rare diseases and rare diseases, another around cancer, and a final one around reproductive carrier screening. And the idea here was to really run a sort of matrix model where big scale issues were being addressed programmatically, as well as exemplar projects or flagships being run to illustrate how to practically apply what was being learnt across these 4 programs. Interestingly, this was an example of where the sort of states got on board. I was in Queensland at the time, as Peter mentioned, as the DVCR, and so we, in addition to the 25 million that the NH and MRC put in, we set up the Queensland Genomics Health Alliance, and the state government in Queensland put in $25 million. Melbourne had already set up their state-based alliance at 25 million. South Australia put in similar money, not to the same quantum, Western Australia. And then in Sydney, they adopted a slightly different approach, but still had a state-based investment. And so as a consequence of this, we really had a national approach to genomics with state-based investment staying in the state, and then this national enterprise really working across those boundaries to unite up all the researchers. So at the end of the day, there was about 80 organisational partners and about 500 investigators involved in this program of work. And I'm just going to run through very quickly some of the things that were tackled. I'm not going to go through any of them in enormous detail, but just to give you a sense of the sort of scale of activities that were really addressed through what was, an NH and MRC initiative really from the outset. The first thing was around consent and how consent should be done, how to develop a national approach, how to make consenting dynamic in the sense of allowing people to update their decisions around participation in research over the course of their involvement in studies. We also, as part of this program of work, said, well, there's no point just doing research if the outcomes of that research doesn't get funded and it doesn't have a sustainable funding base. If the idea here is to produce evidence-based information that can then be used in clinical practice, it should be used in clinical practice, we need to be targeting the evidence towards the reimbursement agencies or the reimbursement systems that fund healthcare. And so part of this was connecting up the genomics initiative to MSAC applications, and the Genomics Initiative, in fact, developed a number of applications. They were recommended for funding and have been rolled out through the MBS funding. And more of these have been coming through the MSAC process. And I'd say about 40% of the submissions we see now to MSAC are related to genomics in one way or another, either testing or therapies. And so this is not the only group that applies for funding, but they are certainly a huge generator of evidence. And the evidence generation is evidence that matters to Australians, that is relevant to the Australian context, and hence I think has a lot of credibility, therefore, with funders, not just the Commonwealth, but also state funders. In addition to the work around consent and establishing evidence bases for testing and the use of genomics in clinical practice, a whole lot of resources were set up. This is just one example here, the Sharient, which was basically around curating variants that had been found in different labs and providing a platform by which you can actually assess whether your variant and what you're calling it as pathogenic or not pathogenic is considered in the same light by other people who are interpreting variants. And so it had gone from a sort of bespoke single lab assessing variants to really a national approach to assessing variants, and hooked in now internationally, which is really, really helpful when you're trying to understand whether your variant in your particular disease has any clinical significance or not. Similarly, other platforms like the Panel App Australia, which is another open online, now virtual gene panel curation platform. This was initially designed by Genome England for the 100,000 Genome Project, but then was used and developed for Australia as well. Workforce education was another aspect of what we pushed for in the genomics area. And just wait 1 second, my battery is low. sorry, I've been on Zoom all day. Workforce education and training was another key aspect of what genomics, what this research enterprise also addressed. And finally, a new feature of that really came out of the genomics area was really looking at variants and their significance where they couldn't be classified through sharing information across different research teams, is looking at establishing a functional genomics network which could actually apply new technologies to determining the functional significance of genomic variants that had been identified through the course of these research projects. As I mentioned, sitting across the top of these major platforms were all these clinical flagships, which were really use cases, I guess would be the best way to describe them, was picking an area and then looking at what was the problem or the missing piece of evidence that needed to be filled in order to demonstrate either utility of genomics or alternatively demonstrate that the application of genomics in these diseases really didn't have a place. And these clinical flagships were very successful. They were led, all clinician-led, all very much driven by clinical need. And I think that was possibly one of the reasons that they were so effective at recruiting patients and actually reaching the targets that were required to be reached in terms of delivering the findings. The genomics program ended in 2020. The NHMRC decided to extend the funding by a further couple of years to finish off some pieces of work. And I'm not going to speak very long about these, but rather just because they're just getting underway now, but just to give you an idea of how this program has matured over the period of the last 5 years. So this is what the genomics ecosystem looks like now. It's a very, very connected up. There's so many people involved in this enterprise. It is really quite extraordinary that such a collaborative enterprise has developed. I think that's partly due to people's passion for genomics, but also I think due to the leadership of Kathy North and the Murdoch and others who are really a driving force for this enterprise. Some of the priority projects for this next period are about genomics information management, about implementing genomics into clinical practice, genomics literacy and workforce training, Indigenous genomic priorities, genomics diagnostic, and I've talked about Sherian and Apple and Panel App already, and then evaluating genomics research and translation. That's really a continuation of some of the work in the first phase of the program. These are additional program goals, which are really now developing into much more, I think, the territory of the actual health system itself to pick up, and where the handover points occur beyond what was essentially a research project now into mainstream healthcare. And finally, another outcome of the program was the establishment under the MRFF of a Genomics Health Future mission, which was announced in just last year or early last year. And that was investing $500 million over the next 10 years in genomics research using a different vehicle, this time not NHMRC, but MRFF. And these programs will be seen on the website. So in the last minute or so, I just wanted to conclude with a couple of reflections from really using my hat, just using my MSAC hat. And I wanted to just share with you some of the challenges that we've had in trying to assess genomic therapies and their value to healthcare. These are the traditional areas that or domains we look at when we're looking at genomics: clinical effectiveness, cost effectiveness, total budget impact, and then how the technology will roll out in the healthcare system. And they all sound relatively straightforward, easy to determine, but genomics presents some pretty challenging problems when you try and look at these things in this broader context. So clinical utility, this is, in shorthand version, what's the impact of using genomics when you combine the evidence, the clinical context? What do you get? What's the bang for buck when in terms of a healthcare outcome, when you invest in something like genomics. And this has been particularly interesting in this area, and I just want to share with you some of our reflections on this topic. And the first point I just want to mention, and I think is it Dave who's got his self unmuted again, is the preference that reimbursement agents have always had for buying health outcomes is around people living longer, living better. Obviously, changing clinical practice is a clearly important part of that paradigm. If you introduce a new intervention and no one picks it up, well, then that's obviously not going to, lead to better health outcomes at all. But with genomics, there are additional value adds. One is about changing family planning options, and that has value. Diminishing diagnostic odysseys, so stopping people having to go through 50 tests when one will do, that obviously has huge value. And then we came up with these other things which have started to, appear in the nomenclature of reimbursement, the value of putting a name on something. So if you have a very rare disease and no one knows what to call it or what it means, even if there is no treatment available, a very strong message back from the community to us to MSAC was really around, it's very important to be able to name things as well, even if that naming a disease does not give you a treatment. And the final aspect of value is also around in just simply confirming that the diagnosis or the label that something has been placed on your disease is actually true. If someone's labeled you as having disease X, it's important that that is confirmed to as great a certainty as possible. Okay, and I'm just on the last slide. And okay, so I think these are. Wow. Oh, sorry, Dave, could I ask you to mute yourself? Okay, anyway, just a final slide here is just really around some of the challenges that I think maybe it's worth discussing, which is this issue about where in genomics, where the population of people that are being asked to actually use the test is too broad. So you want to use genomics to identify people with rare conditions, but where the population of people that are going to be tested is far beyond what is definable by a phenotype. That's particularly challenging. Where the natural history of a condition is unknown, that's particularly difficult in evaluating the real value of genomics and whether intervening is actually going to make any difference. Pathways of care is a huge thing that is being challenged by genomics. It's where it's very unclear at the moment whether the introduction of genomics will be used in specialized services or will be used by general practitioners or in a distributed model. And that clearly impacts on the diagnostic yield. So where a specialist is confirming phenotype and then doing genome testing, you're going to get a much greater diagnostic yield than if that was, say, if testing was released to allow it to be used at population level without any pre-screening phenotyping. Finally, there's a lot of changes in technology, and that's increasingly challenging to keep up with, particularly for the pathology labs, but also the clinicians who have to interpret the results based on different technologies. And then this interpretation of pathogenic variants, despite all this big sharing of information across the country and across the world, we still know so very little about what genomic variants really mean in practice and whether they're really going to influence a disease course. And then finally, and not least, of course, is there's really a lot of discussion going on now around the non-health outcomes, and particularly things like reproductive confidence and placing value on avoiding the birth of affected children, whilst at the same time ensuring that that's not applied uniformly, and value systems that are held by one individual are not placed on others who may make different choices about their decisions in terms of childbearing. So these are all really challenging issues. I guess they all came to the fore through this era of genomics. I'm really glad that there's research still going on, because there's seemingly more to be uncovered than we really have at our fingertips at the moment. So perhaps I'll leave it there and stop sharing, and happy to answer questions, or Peter, you may want to move on to your next section. I hope I haven't gone over time.
No, absolutely perfect. Thank you, Robyn. A fabulous tour over a really large and emerging area that certainly through our collaboration with CMRI, Safe Sight Institute and ophthalmology is sort of in this area up to our necks, with lots of projects and lots of research going on. Robyn, we've got time for a couple of very quick questions or comments. Robyn, do you want to add anything at the...
No,
yeah.
No, go ahead, Robyn. Sorry, Robyn. I thought
Which Robyn?
Which Robyn? Go ahead,
Sorry,
Robyn.
R2.
R2B2.
Yeah, thanks very much, Robyn. That was a great tour de force across all of those areas that are really standout issues for genomics. I guess, you know, on our Sydney level, I guess it'd be interesting to know what your thoughts are in terms of the mainstreaming aspects. So as you would realise, with the advent of genetic therapies now for particularly the inherited retinal diseases, this is a major issue for us, with you know, many patients being seen now who previously weren't being seen because you know, it was thought that there was no possibility of therapy. Many more referrals and so on and so forth. And of course, as you indicate, the genetics workforce has not been fed over the years, and there is a very small genomics workforce, of course, needing a high degree of literacy in that area. We're undertaking a virtual genomic MDT approach at the moment to try to help to deal with that. I think one of the major issues is that obviously ophthalmologists are very busy as well. They have enormous workloads. There are increasing issues that they need to deal with in terms of interpretation, using new technologies for the phenotypic interpretation and so on. So I think you know, mainstreaming is great, but you know, someone's got to do the work. And I suppose you know, I guess it's how we roll that out and how we can make that actually work for the patients.
Yeah, I mean, it's a great summary, Robyn, of all the issues, and I don't think there's a cut and place boilerplate sort of solution for each of the different specialties. I mean, what happens in, you know, in cardiology or cancer or ophthalmology, I think it's really, you know, disrupting those normal, you know, referral pathways, who can be screened, what's done remotely. It's really changing across the board. And I mean, the cardiologists that are in the same position at the moment, really, well, not just the cardiologists, nearly everyone, every specialty is being challenged to rethink, you know, what's my job in this? You know, am I the person that's supposed to do it? When can I use the genetic specialists because they are in such short supply? And what do I need to understand myself? And what else can other people do? I mean, it's really a huge challenge, the upskilling of people, but also, as you say, just coping with the referral pathways and how specialists interact with this there's no easy solution at all. I don't think we'd ever have enough, even if we train so many new genomics specialists, we wouldn't have enough people. So obviously we've got to get in early with our students, our medical students and our health students, and get them literate really quickly, which I'm glad you're doing.
We need it.
Fantastic. Well, look, unfortunately, we'll need to move on to our cases. Robyn Ward, I know you've had a long and busy day, but you're more than welcome to listen to these couple of our two cases. The first one is going to be presented by Linda Zheng from when she was at Bankstown in a very interesting angle closure glaucoma case. So if you could share your screen, that would be fantastic. Thanks, Linda.
Yeah, so I'm doing the case with Sarah, who's going to share the screen.
Mm-hmm.
So can everyone see my screen there?
Yes.
Yeah, lovely. Thanks, Prof. So my name is Sarah Chowdhury. I'm one of the ophthalmology registrars at Bankstown Hospital. I've been given the opportunity to present tonight at Coles with about a case that Dr. Zheng and myself saw at Bankstown and was managed in coordination with Dr. Lim and Huang Tong at Sydney Eye. So we'll get straight into it. The case is of a 78-year-old female who presented to Bankstown Hospital with severe left eye pain and blurry vision around 3 a.m. She came into the hospital around 8 hours later with an intraocular pressure of 70, vomiting profusely and denying any other history of using antipsychotics or other medications or Diamox prior to her hospitalization. In terms of her past ocular history or notable past ocular history, she'd had bilateral cataract surgery done 20 years ago in Australia and was noted to also have PXF, for which she'd never been on any drops. On examination, her left eye vision was 6/36, sapillination pressure was 65. She had an injected STEMI cornea with 1+ cells, some fibrillar deposits on her pupillary margin, and as mentioned before, she was pseudophakic. There was no iris bombay, no rubiosis iridicis, no posterior sneaky, and no transillumination defects on examination. Her gonioscopy revealed a 360 degrees of angle closure. Her posterior segment examination showed a 0.5 cut-plus ratio, no obvious strats, hemorrhages, a flat macula, a clear media, and no other retinal abnormalities. Her B-scan had no choroidals or retinal masses. Her right eye had an unremarkable examination with open angles and PXF deposits on the margin. Immediately, we managed the patient with oral 500 milligrams of Diamox, which unfortunately she vomited immediately. We instilled some pilocarpine and performed a laser PI, which was patent, but resulted in no pressure reduction. She was then commenced on ID mannitol, which brought the pressure down to 38. And so we commenced her on maximal medical therapy overnight. On review the next day, her pressure had crept up again to 42. She, after review with the consultant, underwent a YAG hyalodectomy, and the pressure was 28 up to this point in time. Throughout the day, the medical management was continued, but unfortunately later that evening, her pressure spiked again to 40. And so after discussion with the glaucoma team, she was graciously accepted under the care of Dr. Lim at Sydney Eye Hospital and transferred over there.
So at Sydney Eye Hospital that evening, the glaucoma fellow saw her and performed immediate UBM, which showed 360 degrees of angle closure with a mass pushing forward, closing the angle. She was commenced on maximal medical therapy and advised to lie flat and admitted straight to the ward upstairs. So this is an anterior segment photo of the right and left eyes. Most pertinent finding is that there is 360 degrees of angle closure in the left eye and none in the right. This is the UBM that was performed that night, which shows that there is a mass behind the lens iris structures.
I'll be 10 minutes.
Pushing the angle closed. This is an OCT performed, which shows normal RNFL of 80 in both eyes. And this is a video, an anterior segment photo of the left eye, which shows that there is PXF material, she's pseudophakic, and there's pseudophacodenesis. And as you can see, the angle is quite shallow as well. So in terms of admission, on day one, a vision was 630, pressure was 20. They consulted the oncology team regarding this space-occupying material behind the iris, and it was felt to be non-malignant. She was tentatively pink slip for theatres for goniosynechiolysis and inspection behind the iris, and managed on maximal medical therapy and advised to lie flat. day 2 of the mission, her angle had opened temporally, so the Diamox was ceased and her drops were continued. And by day 3, her angle had completely opened 360 degrees, and she was tapered off her medicines and discharged.
Interestingly, a month or 2 later, she had another presentation for gastroenteritis to Bankstown Hospital and mentioned that she'd had a left eye redness, pain, and blurry vision for the past 2 days on admission. On examination that day, her vision was 612, her pressure was 32, and she had 270 degrees of angle closure with the superior ATM visible. There were trace cells, and her cup-disc ratio was still 0.5. So after discussion with the glaucoma team again at Sydney Eye Hospital, we'd commenced her on the same treatment that she'd had over there and encouraged her to lie flat. And over the course of the next 3 days, her pressure began to drop and her angles opened again completely. On discharge, her pressure was 10 and her angles were open 360 degrees. The diagnosis was made of a floppy iris, likely secondary to PXF, causing a mobile bag complex, as well as a Soemmerring ring behind the iris, causing an anterior displacement of the iris lens diaphragm. So I'll pause it here for comment and discussion.
Rydia, would you like to comment on the case at this time?
Yeah. I don't know if you can see us. Actually, Tung's here as well. He saw the patient originally, and she was, yeah, I mean, I think by the time I saw her, she was starting to be, get back to normal, but she definitely had the extreme intraocular pressure rise and all the acute symptoms. And I think her central chamber was formed, wasn't it? Yeah, her central chamber. We were thinking, well, what was the mechanism? There was no pupil block. There was the central anterior chamber was well formed. But then we thought that there was definitely something pushing from behind, and you could see that Soemmerring's ring, sort of a space occupying lesion. So we got Leanne to have a look. We were pretty sure it was a Soemmerring's ring, but it was good to get her opinion about it. Mm. Yeah, I mean, I think that pseudophakic angle closure is not very common, but when it happens, you have to really think about it in first principles with, because even if you look at the literature, just a Soemmerring's ring can cause angle secondary sort of pseudophakic angle closure, but it can cause it in different mechanisms. It can cause pupil block, it can cause a posterior pushing mechanism. So I think just get back to basics is my message here.
Yeah. Do you think the PXF was important?
Oh, for sure. I think with the PXF, the whole complex is quite unstable. And we thought that was probably the mechanism, which is why Tung said to lie flat. Yeah. And, have it physically go posteriorly, which really we didn't do very much. We just supported her while it really reversed itself. And so we had the discussion, how do you keep that complex from moving? Do you atropinize her or give a pilocarpine, or go in and do something? Yeah.
Okay. Yeah. All right. Thanks. Does anyone else want to add anything at the moment, or we just push on with the case, I think?
Yeah.
Yep. Sarah?
Yeah, okay. So yeah, just as Dr. Lim mentioned, some common causes of pseudophakic angle closure include pupil block, aqueous misdirection, plateau iris. As Dr. Lim mentioned, Soemmerring rings often work in different mechanisms as well to create an angle closure. So they can do so by creating a pupil block, or they can do so with a sort of a posterior pushing of the ciliary body, sort of restructuring of the whole bag complex. I could only find 7 cases in the literature. Most of them had pupil block and they were managed with laser PIs, and one patient just had a very localized mass that was thought to be an iris tumor and then managed alone on glaucoma drops. I couldn't find any cases where there was surgical intervention undertaken or horizontal positioning of the patient seemed to resolve the situation, which was interesting for her case. So I guess the take-home messages from the case are that pseudophakic angle closure is uncommon, but you need to exclude the common things first. Sometimes simple maneuvers really help the most. But my question, I guess, is for her, she's having recurrent episodes, or she's had at least 2 episodes now. Is there any way we could prevent further insult to this nerve more long-term for her?
Rydia, do you want to comment on what your plans might be? You're on mute at the moment. Yeah.
She has pretty good nerves at the moment. So I think that you have to balance. I think it's reasonable to monitor her for now and see what happens to the pattern of her, acute episodes. So you've definitely got time to see what happens, but it might be necessary if it becomes a frequent occurrence and you start to see glaucomatous optic neuropathy to do something about it. Yep.
Okay. All right. Well, look, a fascinating case, a rare one, and shows you that all surgery, even the best phaco surgery, can cause unusual complications. Thanks very much, Sarah, Linda, and Rydia. We might move on to the second case. Will Yates is going to present the second case, and I will hand over to Will. And thanks, Will. You're on mute, Will. You need to unmute yourself.
Sorry. Thanks, Prof. Can everyone see my screen there?
Yes.
Okay. And that's just the slide you're seeing now?
Yep. Yeah.
Yeah, great. So this is a case now focusing on the back of the eye that I'm presenting on behalf of Prof McCluskey and Prof Grigg, and it's an interesting case, which is a 30-year-old gentleman who, prior to October 2016, had, other than some myopic astigmatism, no family history of any ocular problems, no family history, and his medical history was unremarkable. But unfortunately, in 2016, he was diagnosed with metastatic melanoma to the brain, liver, lungs, and nodes. Subsequently, in the modern era of oncology and immunotherapy, he was started on nivolumab and ipilimumab in November 2016. And my understanding was that he was having a very good response to the immunotherapy. In March 2017 or thereabouts, he noted to develop visual symptoms where he was developing night vision problems, difficulty navigating at night, or nyctalopia, floaters and flashes. Subsequently, due to ongoing issues with the immunotherapy and multiple oncology reviews, he didn't really seek attention to an ophthalmologist until a few months later. And he was noted to have retinal periphlebitis and cystoid macular edema, suggestive of an inflammatory insult to the back of the eye. The ophthalmologist who saw him in the community determined that he had evidence on his fluorescein angiogram of periphlebitis, which was non-occlusive. And he was treated with a short course of oral steroids in August 2017 and noted to have a very good response, both with the periphlebitis and the cystoid macular edema. So he was referred to the SafeSign Institute to try and figure out, well, what's the diagnosis? So at the review, he was noted to have good visual acuity of 6.6 in both eyes, good near acuity, normal intraocular pressures, and normal optic nerve function, including colour vision. His anterior segment demonstrated no evidence of any inflammatory cells or evidence of previous inflammation. The vitreous had occasional cells, and his wide field imaging, as you can see, demonstrates otherwise unremarkable, healthy-looking discs, healthy-looking vessels, an intact foveal reflex. His fundus autofluorescence, however, does show that he does have this subtle hyperfluorescent ring, predominantly at the posterior pole. He subsequently had electrophysiology. He had an OCT, which demonstrates this cystoid macular edema, which was noted to be present in both eyes. But most strikingly, he had this attenuation or loss of the ellipsoid zone, or evidence of photoreceptor destruction. And you can see it was worse in the left than the right, with pretty much parafoveal area totally disrupted in that ellipsoid zone. He subsequently had electrophysiology, and this is the scotopic or looking at really the rod system. And you can see that he has really no A wave on the very dark adapted trace, as well as an electronegative B wave. And coming down to his dark adapted, which you can see that he has an electronegative B wave, but he has some evidence of an A wave suggestive of more inner retinal dysfunction. So the rods themselves seem okay, but there is an issue with the inner retina, suggestive of the either the bipolar cells, and specifically the on-bipolar cells. And you can see that it's asymmetric, very much worse in the left than the right, as you can see that the box really gives us an indication of what's the normal tracing. I'll move on to the light adapted, and then I might hand over to Professor Grigg for his comment. So the light adapted is more indicative of the cone system. And you can see that on the light adapted 3, that he does have a subnormal A response, suggestive that the cone system is working with some input from the off bipolar cells. And you can see that his light adapted 30 Hertz suggests some rod function, but just suboptimal with some latency there. I might hand over to Prof. Grigg to get his comments about this, if you're on, Prof.
Yeah, thanks, Will, and thanks for the case so far. Basically, the electrophysiology helps in this case where there's a relatively normal or non-specific clinical examination, and it helps us to dissect out what part of the retina is involved. And so in the dark adaptive, we're looking at the rod system, and as Will showed, we basically showed there's a real problem with the rod system, and then we can show that the rod photoreceptors are working with the normal A wave, and the B wave, which represents the bipolar cells, are affected, and it's asymmetric. Now, this pattern can be seen in inherited eye diseases, such as congenital stationary night blindness, or in acquired diseases, and melanoma-associated retinopathy is one of those conditions. And I think Will's going to go on and talk a little bit more about that, but the electrophysiology has provided us with the most likely diagnosis now for this gentleman, particularly in this clinical setting, and it has some help for prognosis and looking at the responses going forward. Thanks, Will.
Thanks, Prof. So turning to his pattern ERG, it just demonstrates that he has generalized macular dysfunction, and the multifocal ERG, which is a topographic representation of the macular function, again demonstrates sort of diminished macular function. So as Prof mentioned, we thought the unifying diagnosis was not one, but possibly two mechanisms. So number one was the melanoma-associated retinopathy, predominantly given by the dysfunction of predominantly the on-bipolar cells on electrophysiology, as well as checkpoint inhibitor uveitis, given that he had evidence of periphlebitis and cystoid macular edema. So we thought this gentleman actually had, in fact, both diseases, which hence Hiccum's dictum. So he was continued on nivolumab and ilopilimab, and it was ceased with subsequent tumor regression. However, in close consultation with his oncologist, he was started with systemic immunosuppression, because on one hand, we're trying to amplify his immune response, but on the other hand, we're trying to prevent further destruction to the visual system. So the addition of mycophenolate and tolerated this very well, and intraocular, he had some ocular therapy, including intravitreal anti-VEGF injections to improve his macular edema. Because he was young and phakic, they didn't pursue intravitreal steroids due to the risk of cataract. And he did have progress electrophysiology, which was unchanged in 2018. But most strikingly, I want to draw attention to his left wide field imaging, both of the fundus photograph and the fundus autofluorescence. And you can see in 2017 that really it looked otherwise normal. However, in 2020, you can see that he has pretty much an albinoid type fundus with significant loss of the RPE, the pigmented cells of the retina. And you can see that the overlying choroidal vessels is very, very evident. And he still has that persistent hypofluorescent ring, predominantly the posterior pole. And we think this was predominantly due to the to the checkpoint inhibitors, as it's well-known phenomenon that they do develop vitiligo as a response to the immunotherapy. So I might, Prof, do you want me to move on and discuss further?
Yeah, I think that'll be good. I think I'll go to the next.
So I guess I just wanted to discuss a little bit more about melanoma-associated retinopathy, which is a well-known paraneoplastic syndrome of the visual system. And it's thought that there's shared neuroectodermal lineage between the melanocytes and the retinal cells. And that as a result of molecular mimicry, tumor antigens develop between the tumor antigens and the retinal proteins. And we think to explain the electrophysiology, as well as the findings that we see with the nyctalopia and the night vision, is that they develop an antigen to the TRPM1 protein, which is on the postsynaptic area of the transduction pathway, predominantly on bipolar cells. And this is a well-known gene mutation that's associated with congenital stationary night blindness. And interestingly, it's also a gene that's gene and protein that's expressed in the melanomas and is possibly lost in aggressive melanomas, and is indicative of aggressiveness and possibly the risk of metastasis. Interestingly, there's this breed of horses called the Appaloosa horses, which are quite a common breed, horse breed in the US, which have the TRPM1 gene mutation, which gives these horses their sort of leopard spots. And interestingly, if both horses have a homozygous, both have a mutation in both alleles, the horses themselves develop congenital stationary night blindness or night blindness, which makes them not a particularly useful horse for training in the middle of the night. I guess the important thing with melanoma-associated retinopathy is the fundus can be very unremarkable. They can have this subtle hyperautofluorescent, but it's really the diagnosis really comes in the electrophysiology. And I might just change direction into the checkpoint inhibitor uveitis, and if Prof Ward is still online, I might just get her help to explain some of this, some of the checkpoint inhibitor uveitis. But the two common ones that are commonly used in melanoma and small cell lung therapy are ipilimumab and nivolumab, which is a cytotoxic T cell associated protein, which is bound on the tumor cell, which inhibits the regulatory T cells from attacking it. And so if you block this receptor, it results in the T cell activation, and then these T suppressor genes then becoming less active and amplifying the host T cell response. And there isn't evidence that this programmed cell death ligand is expressed in the RPE, and hence why there is increasing literature of a wide variety of uveitis associated with the checkpoint inhibitor-induced uveitis, with ranging features of onset of inflammation in the eyes, ranging from sort of within the month to 3 to 4 months down the track. Often they're just treated with systemic steroids plus or minus immunosuppression factor, trying to balance up the immunotherapy to try and fight the cancer or the malignancy, but also trying to protect the visual system from further damage. Often they do have suspension of the immunotherapy if it can be allowed, or occasionally it's discontinued. So I guess in summary, this gentleman had dual pathologies, both MAR and checkpoint inhibitor-induced uveitis. And I guess there's a number of important learning points, including the fact that we need to be aware of these checkpoint inhibitors and their possible effects on the visual system, as well as the importance of multimodal imaging, and again, when and how to order electrophysiology, because I think that was the clincher with this case in terms of making the appropriate diagnosis. So I might leave that there.
John, would you like to make any comments, or Robyn Ward, would you like to make any comments?
Yeah, I guess just the first generation immune therapies, ipilimumab, and then next generation pembrolizumab, nivolumab, they've all been amazingly effective at treating melanoma. There's no and a range of other conditions, lung cancer, renal cell cancer, etc. But they all come with a whole range of immune, autoimmune responses, and they often persist even after the treatment has ceased. So you've highlighted one, but the range of systemic effects are everything from endocrine abnormalities to neurological diseases, myasthenia gravis, meningoencephalitis has been reported now, neuropathies, liver failure. So there's not an organ in the body that is not going to be a target of a collateral damage when you use checkpoint inhibitors, particularly when you use them in combination. So, I guess this is another example of great treatment. Does a lot of people are alive today because of these therapies, but they do come with a range of side effects. And if you develop one of these more serious ones, that's it's particularly difficult to manage.
Yeah, thank you. Yeah, John, do you want to add anything from an ocular perspective?
I think it's just early on in the melanoma-associated retinopathy, there's quite a mismatch between the function and the structure. So the eye can look relatively normal, yet the function is quite poor, and that it may, and we're not sure whether it's reversible, but the longer it goes on, then leads to destruction. But that's where the electrophysiology can help pinpoint this in its early phase. What we're not sure is what happens when you stop the checkpoint inhibitors, and if you've sort of managed to halt the metastatic melanoma, will you get some function back? And I suppose that really depends on how much residual photoreceptors survive the process.
Yeah, thanks. All right, well, look, I think we're right on time. It's 7:02. I'd like to thank particularly Robyn Ward for a really interesting tour of genomic medicine and how we're going to need to apply it and highlighting some of the problems. Thank you very much, Robyn. Thanks to the trainees for excellent case presentations, and thanks everybody for attending. It's, I think, been a really enjoyable Coles Colloquium. Thanks very much. Have a good evening, everyone. And as they say these days, stay safe.